My name is Jorge Roche, and I'm the CEO of STARTS, and I will be your MC tonight. First of all, on behalf of STARTS, I would like to acknowledge the traditional custodians of this land, over which sovereignty was never ceded. I'd like to acknowledge the elders, past, present, and emerging. I acknowledge the ongoing trauma of colonization and dispossession. I support justice for First Nations people and welcome any First Nations people in attendance today. Let me tell you a little bit about STARTS, since we are joined today by people not just from Australia and New Zealand as usual, but also from other parts of the world. STARTS is a New South Wales service for the treatment and rehabilitation of torture and trauma survivors. STARTS is a specialist, non-profit organization that for over 30 years has provided culturally relevant psychological treatment and support and community interventions to help people and communities to heal from the scars of torture and refugee trauma and to rebuild their lives in Australia. STARS also fosters a positive recovery environment through the provision of training to services, through advocacy, policy work, and through partnerships with communities and other agencies. STARS Clinical Masterclass program has been going on for 15 years now. Unbelievably, it seems that it was only yesterday we were starting it. Every year we hold 5 free events that are open to anyone interested in learning more about providing crucial clinical treatment to people who have been tortured and or suffer other types of traumatic events in the context of organized violence, forced displacements, and the refugee experience. These lectures are recorded and published in the online psychological journal called OWL Talks, where they can be viewed for a small fee. Staff and associates of RCT member agencies can access this resource for free by the FABO website or by getting a password from us. Attendees who registered in advance and who display their full participant name while logged into this webinar will be able to receive a certificate of attendance sent by email over the coming days. So let's move to tonight's event. Tonight's event will be on the topic of clinical work with prolonged grief amongst refugees, from research to clinical implications and treatment. Obviously, it's one of the core issues that we deal with at STARTS and over all of our sister agencies in Australia and all over the world. Our first 2 speakers, the first speaker will be Professor Richard Bryant, who's been for a long time close partner with STARTS and is very well known in the field of trauma. He will be followed by Nuria Mehrabi, one of our counselors and clinician trainer who's been with STARTS also for a long time. This will be followed by a panel discussion. This will function a little bit different to others that we have held over Zoom. So please type your questions for the speakers into the Q&A box. If you like questions, that somebody else is put up, please vote it up so that it moves up in the agenda and I know which ones, are the most popular. I will read out the questions and invite the speakers to answer them. If you have any questions related to any technical issues or comments that you would like to make, please use the chat box. STARS Zoom support people will try and assist you with any problems that you have. So let me now introduce our first speaker. As I said earlier, Professor Richard Bryant is a close colleague and friend of STARTS and has appeared in these clinical masterclasses, certainly more than once, and also some of our research seminars. He is the group leader of the Westmead Institute's Traumatic Stress Group, which is part of the Brain Dynamics Center. He is also a Science Chair Professor of Psychology at the University of New South Wales in Sydney. He's also an Australian Research Council Laureate, Fellow and Director of the Traumatic Stress Clinic at Westmead Hospital. He's a very prolific writer with over 350 articles published on trauma, anxiety, and treatment. He is currently studying the effects of complex trauma on clinical presentations, including those of refugees and torture survivors. He also serves on the committee addressing complex PTSD for both the DSM-5 and ICD-11. The traumatic stress clinics that he runs provides cutting-edge evidence-based treatments and undertakes world-class research for post-traumatic stress disorder and prolonged grief. The clinic is an affiliation between a number of researchers, organizations, and clinical psychologists, and is directed by Professor Richard Bryant himself. The Traumatic Stress Clinic is based at the Westmead Institute for Medical Research and at the University of New South Wales in Sydney. The title of Richard's presentation today is Prolonged Grief in Refugees. So thank you for joining us today, and over to you, Richard.
Thanks, Jorge, and good evening, everybody. And thanks for joining us in this very, very different environment. But I guess this is a strange world that we're all getting used to. Because we started a bit late, I'm going to try and cut my talk a little shorter than I was planning, to sort of save some time, assuming that you don't all want to spend all night on Zoom. So what I'm going to do here is share my screen to show some PowerPoints to you. And just so that you're not all scribbling notes, these PowerPoints are being shared. And so STARTS will be distributing the PowerPoints to people who want them. So I'm going to give you a little bit of background about prolonged grief in refugees. Now, as Jorge said, and sorry, I'm just having a trouble forwarding slides. There we go. Prolonged grief disorder is now being talked about in diagnostic terms. It never has before. I'll talk about that in a minute. But recently, the World Health Organization has formally included it in ICD-11, which is the new version of their diagnostic system coming out in the near future. And DSM-5, which is the big American diagnostic system for psychological conditions, they initially rejected prolonged grief as a disorder a few years ago in DSM-5, but they're currently revising that, and it looks very likely that they'll be including it in a revision of DSM-5 in the near future. And it looks like their definition is going to be very similar to what ICD-11 is doing. Now, what is prolonged grief? There's been a lot of debate about what it is and what it isn't, but essentially it's defined as this. The key symptom or problem, if you like, is the person who's bereaved has an intense yearning or longing for the person who's dead. Now, this is very common, it's ubiquitous, it's what we all feel in the aftermath of losing a loved one. That's not abnormal. But this is very strong yearning that lasts. And it's associated with a lot of emotional pain. And very often it's accompanied by a range of different types of symptoms that can include the person feeling very bitter over the loss, having difficulty accepting the loss. And so by that I mean they know the person's gone, but they're showing emotional signs that it's hard to accept it. The sort of things that we will see in our clinic is where a person, years after the person may have died, they're still laying out dinner for them every night. Their bedroom is kept as a sort of a shrine. There's all those sorts of behavioural signs where the person really isn't able to do things to suggest that they're emotionally accepting it. Often there's a crisis in the sense of who I am as a person. So my sense of identity has been shattered, and this is typically a result of the person's identity and who I am is so enmeshed, so tied up with the person who's gone, that when they are gone, I don't know who I am anymore. There's also a very strong sense that life is now meaningless. It's empty because this person was such an important source to my life, to who I am. Now they're gone, I've got nothing else, and life has just got no purpose. And very commonly, people have enormous difficulties in engaging in new activities, in relationships, either resuming what they had before or engaging in new ones. And really importantly, ICD says these symptoms have to persist at least 6 months. Other systems are arguing 12 months. Now, this is important because it is saying that we're not capturing all people here who are having grief symptoms, which all of us do, but rather it's people who, beyond this time frame, are still, the emotional pain is not abating at all. And that decision was made because statistically studies tell us that after 6 months, the intense acute pain tends to ease in most people. That doesn't mean they've got over the death, don't get me wrong, but the intense pain tends to ease a bit. And for people where it isn't easing, that tends to be indicative that there's going to be a longer term problem. But what's built into all of the diagnostic systems is that we've got to consider all of these symptoms in the context of the person's cultural situation. Not all cultures have the same conceptualization of grief. How we mourn, the mourning rituals are very distinctive culturally. And so how one determines whether somebody's having a understandable or a non-understand, a severe reaction does need to be seen in that context. Now, part of the reason why we give a lot of attention to prolonged grief is that it is associated with a range of important mental health and also just general physical health parameters. It's increased with, it's associated with marked increases in suicide, in comorbid psychological disorders, a lot of risky health behaviours, so it's increased smoking, alcohol use, drug use, and it's even associated with increased cancer and cardiovascular problems. Now, if we look at some of the best representative population studies done, prolonged grief tends to affect about 7% of bereaved people. And this is important to note because one of the criticisms of the diagnosis is that it was over-medicalising the condition of grief. And really, it doesn't do that. It captures a small proportion of people. But when you look at how many people die each year, even in Australia, that probably equates to at least 50,000 new cases in Australia each year. But we know that that rate is not the same for everybody. We know there are certain sorts of death that really make the likelihood of developing prolonged grief much, much higher. And clearly, you will realise this has a lot to do with refugees too. Suicide increases the risk a lot, but homicide and violent death also does, unexpected death, and the death of a child. These obviously are really difficult for people to cope with, and it really increases the likelihood that a person will get stuck in their grief and really will not be able to adapt the way that we hope most people will. Now, there have been a lot of controversies about this diagnosis being introduced. And look, in the interest of self-disclosure, I should admit to you that, as Jorge mentioned earlier, I was on the DSM-5 and ICD-11 committees, and I'm the guy who basically introduced prolonged grief onto both committees. And DSM-5, I argued strongly that I thought it should be there. It got argued down, and I argued the same in ICD. And the World Health Organization, which takes a very global mental health perspective, was a lot more sympathetic to it because it deals with a lot of low and middle income countries, and it realizes that violent death as a result of humanitarian crisis, war, civil conflict, and just poverty does result in a lot of very problematic grief reactions. Now, some of the controversies about it was that it medicalizes grief, it dehumanizes it in a way. But as I said earlier, I don't think it does do that, because it really only describes about 7% of people. And these are the people who, well down the track after somebody's died, are suffering a lot more than they otherwise may be if they were given help. It is suggested that it does ignore cultural differences, and to be honest, I think the jury's still out on that. We know that a lot of the basic definitional issues about grief hold very constant across many, many cultures, Eastern and Western, individual and collective. It says that it neglects religious factors. And again, I would point out that prolonged grief doesn't speak to mourning rituals and how people understand how we deal with dying and how we conceptualize the afterlife. I think it's a different dimension when we talk about prolonged grief. We're really talking about a mental health issue. It's about, in the aftermath of losing a loved one, as time goes on and I haven't adapted, am I really suffering something significant that's causing me impairment? And others explained that we didn't even need the diagnosis because it can be explained by what we've currently got. Things like anxiety and depression, which for decades was how people understood problems after bereavement. But I guess the evidence we argued in the committees for why we needed it is that it is associated with a lot of psychological and medical problems. The construct of prolonged grief holds across many, many cultures. And as I'll talk about in a minute, there's important treatment implications for how we manage grief, because numerous studies tell us now that antidepressants can address depression after bereavement, but it doesn't really touch the grief. We need something different if we're going to help people deal with grief. As I said, a major debate was about, is it really distinct from any other diagnoses? But there's been tons of studies done that have looked at the different factors of symptoms. And to cut a long story short, basically all of these say that at least half of the symptoms that we're trying to explain can't be accommodated for by depression and anxiety. It's distinctive to grief. This is more just a visual display, but it highlights that what we're seeing here is that grief does overlap with depression, it does overlap with anxiety and PTSD, but there's a lot of it that's distinct. And that's the core bit that's actually contributing to a lot of the impairment that we see in these folk. And one of the other really distinctive aspects of grief is that it's got a very, very unique predictor that you don't see in other conditions, and that is the issue of attachments. Many studies have shown, either assessed before the person died or after they've died, that it's how dependent you are on that person is just absolutely key. It's the extent to which, if you like, a person is enmeshed in a relationship. And I know it always sounds very romantic on a Hallmark card, you know, to say that you are everything to me. But when somebody really believes that, and then that person goes, then they're left with nothing. And it's this highly emotionally dependent relationship that people have on others. This is what makes them highly vulnerable to prolonged grief when that person dies. And this often comes back to their own internal attachment systems, because people who don't have good, secure attachment systems are really more at risk. And this has been shown over many studies. And again, if we come back to just to highlight the predictors and sort of honing a bit more in on the refugee story, we know that traumatic deaths, homicides, sudden deaths, etc., really increases the risk. If the person's been through traumatic events, not just the cause of the person's death, but they've just been exposed to trauma, that increases the risk. the number of bereavements is a big predictor. It's like people can cope with one or two, but as the number builds up, it just wears them down. And we know how many bereavements many refugees suffer. And we know the death of a child is just tragic and difficult for anyone to bear. And it is unfortunately something that people in war zones and in many, many refugees have to deal with this. And similarly, just the whole notion of unexpected death. It may not be violent, but a lot of people in refugee camps, because of poverty, lack of food, clean water, etc., they also have unexpected deaths that, in a sense, don't give them time to prepare for what's going to happen. We also know that grief is strongly predicted by how people think. So nearly every study tells us that it's not just the event itself, but it's how people interpret it. So life has got nothing to offer me anymore. Or maybe I feel guilty because I'm not mourning the way I should, or I'm not recovering the way I should. Or now that she's dead, I'm now a worthless person. All these sort of statements reflect appraisals that are going to make the person feel worse than they need feel. And it's characteristic in nearly everybody who does have prolonged grief. Now, surprisingly, we don't know an enormous amount about grief in refugees, surprisingly. We did probably the first representative study recently where we looked at the people in the Building a New Life in Australia cohort. Now, I'm assuming people here know about this study. Large cohort study of refugees in Australia commenced about, what is it now, 6 years ago or something. And its intention was to assess refugees annually. And it's meant to be representative of a number of major refugee groups. I think the first wave was in about 7, 8 years ago, actually, and I think it's so we really don't have Syrians in this cohort. But in the latest wave, our group also assessed for probable prolonged grief disorder. And we ended up being able to interview basically 1,800 refugees. And essentially we found that 38% did report bereavement, but surprisingly 16% met criteria for prolonged grief. And that's basically double what most studies find, which is normally around 7%. And it was 6% of the entire cohort. Now, most big population level studies find about 3% of a population normally has prolonged grief. But in the refugee population, it tends to be about double that. I thought I'd also share with you some preliminary data. I do emphasize this is preliminary. We've just looked at some data of a study I'm doing in Jordan, in a Syrian refugee camp, at the Azraq refugee camp. You've probably heard of Zaatari, which was the first big camp in Jordan. Basically, it was bursting to the seams a number of years ago, so the Jordanians built a second camp, Azraq, where they could sort of move a lot of people over to this camp. It's now only got about 40,000 in it. I'm doing a big treatment study there at the moment that's just finishing up, but as part of that, we assessed people, and we just basically went caravan to caravan and assessed one person from each caravan. And essentially we found that 56% had experienced bereavement. And of these, 49% had prolonged grief. Now, don't get too excited about that number of 49%. I personally think that's a huge exaggeration, but that's not the point. The point is that the rate of prolonged grief in the Syrians, and this is sort of more recently in the sense that they're still living in a camp, etc., was mind-boggling. And it just speaks to the amount of war, torture, loss of life in their families that they had experienced during and since they'd fled. But it just highlights what an issue this is, and I know Nuria will speak to a particular case about this later. Let me tell you a little bit more about what we know about treating it, because we've now got in the literature a bunch of trials that tell us that what we might call grief-focused psychotherapy is the best thing we currently have. And what it typically involves is a bit of education. We typically teach people cognitive reframing strategies which speak to those appraisals I mentioned. So it tells people about how to identify how they're thinking about themselves or about the relationship that they've lost or about their futures, and to think realistically. So for example, if somebody believes that I have no meaning anymore, we might work with that person in terms of trying to explore other sources of meaning. Even though the person's gone that they love so much, there might be other people. There could be children, there could be a job, there could be other things, their mosque or their church or whatever that they could work with. We then do something that's been built into every trial to date, which is some form of exposure. And by this is normally exposure to the memory of the death. Now, I know that sounds pretty intense, and it is. But what people tend to do is just for about 10 minutes in a number of sessions, get them to go back over the death and to basically process it emotionally. And they do this because they feel that the emotional processing is important, because many people avoid this, and that makes it hard for them to work on other aspects of therapy because they haven't really felt what they felt. We've had people come to us in our clinic and they've lost a child 30 years earlier, and they've honestly never discussed it with anybody, including their wife. So it's important that people can access those emotions. We then do something called communicating with the deceased, which we find a very useful strategy, which is a little bit like the old empty chair technique that you might remember. And essentially we would literally use an empty chair, and we would often have the person pretend the dead person's in the chair and talk to them, either letting them know what any outstanding issues are that they have about the loss, about the therapy that they might be having, about any cognitive reframing we're trying to do, about any issues at all. And the reason for this, it just brings the reality of the therapy a lot more alive. We're not talking abstract terms, we're not talking head level stuff. It's in the here and now because we can imagine the person is here and I can talk to them directly. Now, all of those strategies are seen as like dealing with the trauma and the difficulties of the past. It's processing the grief, but then we need to allocate sessions to more setting future goals, planning new activities, encouraging new relationships or resuming old relationships. And this is more about restorative features of treatment, which is seen as really, really important. And normally these sessions go, it's not a quick treatment, it's usually done on an outpatient basis, usually for an hour per session, and normally it would go between at least 12 sessions that people can benefit from it. Now, the first trial that came, there's been numerous trials that have come out. I'll speak to a couple of them. Kathy Shear from New York is a major player. In a study a number of years ago, she randomized 150 people to either cognitive behavior therapy or interpersonal therapy. Now, interpersonal therapy, as you might know, is a very traditional psychotherapy that's very good for depression. So you'd think it might work with grief as well. And she just recruited older people. And basically she found that the complicated grief treatment did markedly better than the people in interpersonal therapy. She subsequently did a huge trial, nearly 400 people, and she randomized people to either citalopram. Now, citalopram is an SSRI, which of course is, your standard treatment for depression, or to a placebo, or she combined each of those with her grief-focused psychotherapy. And this is a bit of a difficult PowerPoint to look at, but in essence, it's saying that it was only the people who got the grief-focused psychotherapy who really improved the most. The drug didn't help, and the drug didn't even help psychotherapy. And the takeaway is that the grief-focused psychotherapy at the moment is the way to treat. Now, all the trials to date have involved this exposure, emotional processing, but I got to tell you, it's demanding for people. So we wanted to know whether is it necessary. So we did a trial where we compared people who received our grief-focused therapy either with or without the, if you like, reliving the death. And essentially we found at 6 months and also at 2 years later, the people who did the emotional processing, the exposure, they were doing markedly better. And again, as all my therapists told me, they always found that the people who did the exposure, they were able to do so many more aspects of the treatment because they had processed what they'd been through, as difficult as it was. Now, I do need to emphasize that we do have a lot to learn about cross-cultural factors. There have been many, many studies done in many different cultures, and we know that prolonged grief is a stable construct. But in terms of how do we assess it? How do we treat it? How do we conceptualize it in terms of the nuances of culture? And I know I don't have to speak to this audience much to convince you of the importance of that. We're only at the beginning of really learning how to do that. And similarly, in terms of the mechanisms, what actually drives a healthy versus an unhealthy trajectory of grief? And really, what is the long-term course? And how do we adapt the treatment to help refugees from different cultures? We are really at the very, very beginning of this. So, you know, we do have to accept there's a lot we don't know. And I didn't mention it earlier, but with all the best treatments we've got at the moment, at best, probably 2/3 of people respond to treatment. So at least 1/3 are not responding, at least. And we do need to be honest about that. And I think complicating this is that many, many refugees, particularly those from high conflict zones, are going to experience prolonged grief alongside other conditions, including PTSD, because of all the trauma that they've been through. And we do need to makes the story a lot more complicated. And I think also being aware that being a refugee, nearly by definition, means that you do have fractured attachments. You're taken away often from your own social network, from your home, your homeland. And in a sense, that's something that underpins grief. And this again just highlights, I think, why we need to understand grief so much better in refugees, and particularly from different cultures, because we really just are at the beginning of learning it. Okay, I am going to stop there. Yes, we'll have questions after Nuria speaks.